What I remember was discovering drink, being very depressed. I mean, I felt suicidal. I've had chronic depressive episodes where I have tried to take my life, so I understand. It felt like a fight in my head between a part of me that was trying to live and a part of me that wanted to die. On average, from the first point when somebody has a problem until they first ask for help is on average 5 years. People say, oh, just talk, and that kind of thing. I could talk, but you wouldn't understand.
Yes.
That's the problem with mental health. It's this smorgasbord of different things.
Yes.
When I look back at kind of my time, they waited till the bitter end, until it was so obvious before kind of anyone either did anything or they asked for help.
What can we do different?
Be honest, I think.
Welcome to the Living a Life and Balance podcast. My name is Abdullah Boulad. I'm the founder and CEO of the Balance Rehab Clinic. My guest today is Robin Lefever, addiction recovery expert, treatment pioneer, and lead clinician of the family-run Promise Clinic and newly acquired Cardinal Clinic. In this episode, Robin shares his extraordinary journey, healing from self-harm, addiction, and depression through recovery. He opens up about his suicide attempt, how mental health problems build slowly over time, and why it's critical to intervene before people reach their breaking point. Robin explains why shame-free holistic care helps people reclaim what addiction has taken from them. He also shares his candid views on how the industry must evolve from ending the one-off treatment model to creating environments where people genuinely want help. I hope you will enjoy. Robin, what motivated you to do what you do today?
I mean, I guess you'd say I'm a poacher turned gamekeeper, because I had a very kind of mixed up kind of childhood and ended up with addiction problems. And luckily enough, if you're going to have addiction problems, it's really helpful to have a family who own a clinic. And my parents had founded a clinic. And so I went there quite early on. That was the kind of inspiration to do it, but not right away. I mean, so I had this kind of mixed up childhood and kind of some traumatic events, and kind of started self-harming when I was 11 and drinking when I was 12, and then went through 11 schools in 8 years. It was all very dysfunctional. Funnily enough, one of the schools I went to was just down the road here. It was about 20 miles down the road. Better not name it. And I went to, I was thrown out at 16 for taking taxis to the pub and charging them to the school account, because I was already drinking so much and kind of like so out of off kilter. And then kind of I went to a tutorial college in London, which is where all the other people who had drink and drug problems who'd dropped out kind of went to. And then my parents kind of got into this field. My dad had been inspired. He was a doctor. He'd been inspired by seeing a client get well and wanted to understand how. And I don't think he was really kind of aware of our own family sort of history of addiction and stuff going on in the family. But he was really inspired by that. And then unfortunately, he became more aware, unfortunately for me and my addiction. And, and he made a very reasonable proposition, which was that he didn't want me to carry on using drugs in the house. And I reframed that as, you're throwing me out and I'm an orphan. It was all very dramatic. And so I left home at 17. And some friends of mine started working in the city. It was a lot like kind of Wolf of Wall Street, dodgy kind of stuff. And I kind of went into that, being somebody with an addiction problem. It was the kind of perfect environment to carry on. But I must admit, at the same time, I was kind of unhappy enough to ask for help. And my parents had offered to let me get help. And so I did dip my toe in treatment, and I went to their clinic for a couple of weeks. And then I kind of walked out of there, and then they sent me to America, to Hazelden. And then they threw me out after a couple of weeks. I mean, not got a great kind of like...
You were one of them.
Yeah. But funnily enough, I came back and I stayed kind of clean and sober, if we still use that phrase, for a year after that. So I obviously had, a deal of intent, although I don't think I wanted to do kind of the rest of the work that would be necessary to sustain a recovery. And, basically I just had that idea that I'll try and take drink and drugs out of the equation. Everything else would be fine. I'll carry on living the same life. And that didn't work. So eventually I obviously started using, but quite a little while later, wanted to come back into kind of recovery. So it wasn't finally until I was 23. Although it sounds like an epoch, doesn't it? Now I'm
Mm-hmm.
nearly 60, and I'm kind of thinking about, wasn't until the ripe old age of 23.
Yeah.
But like at 23 was the kind of final time I went back, and I actually completed treatment, and I went to a halfway house, albeit briefly. It wasn't perfect
Yes.
treatment episode, whatever that would look like. And then, sorry, I was a bit of a monologue, but I mean,
Mm.
in early recovery, I kind of, I mean, it's difficult, isn't it? I imagine if people, when they kind of come into recovery, they're probably inspired. I was definitely inspired by this
Mm.
kind of mercurial kind of world of therapy and psychology. I mean, I had lots of other interests of computing and things like that. But I'd also missed out on university because
Mm.
of my addiction. And so one of the things I really wanted to do was to go to experience university. I was teasing my parents when I went that I wasn't going to get my actual degree because I don't value the bit of paper,
Mm-hmm.
but I really wanted that experience of being in an environment with lots of people who are super interested in their subjects. So I went to university and studied psychology.
Mm-hmm.
And then kind of shortly after that, it's kind of like really difficult. I've got my parents, they've got a clinic. I'm,
Yes.
studying psychology, super interested in therapy. You know, they
Okay.
asked if I would join, and of course I did. And it was
Mm.
fascinating and
Mm.
amazing to be kind of involved in the kind of whole therapy world. So sorry,
Yeah.
it's a heck of a long origin story, but yeah,
That's
that's how
great.
I kind of came to be interested in it and come to work in it.
Yeah. No, thank you for sharing that. And one could think like, yeah, if the parents run a rehab or an addiction clinic, you have all the resources and the tools at home
Yeah.
to not get into it. But this was clearly not the case in.
Well, no, I mean, I was thinking you were gonna say it the other way around, which is probably true, which is that we've got, enough
Mhm.
people in the family to keep a small clinic going.
Mhm.
So, so no, I mean, and I think, yeah, I think that was the interesting thing about my father kind of sort of getting his own awareness,
Mhm.
because initially it was, he wanted to help other people, then he recognized his own processes and was very open. And that
Yes.
was quite a brave thing to do for a
Mhm.
doctor, back then, to kind of talk about being in recovery and in
Mm.
his own journey. It was groundbreaking. It was really not the thing that was done in the medical world. Um, and and then kind of, I guess he kind of broadened his kind of realization that there was something going on
Mhm.
with me and kind of other members of the family, and kind of, and then I think your other point is also right, which is that as I've kind of been in recovery and been working in
Mhm.
this, as my other members of my family have had their own difficulties, I think the fact that I'm kind of modeling in a way, and it's just part of our family culture to kind of
Mm.
have an understanding of mental health, and to kind of respect people needing to do a bit of work here and
Yeah.
there, has meant hasn't meant that they've dodged all the bullets of having,
Yeah.
they got my genes, so
Yes.
they couldn't escape, all of
Mm.
the problems, let alone my poor parenting. So kind of that combination, means that they kind of had their difficulties, but it also means that they've asked for help and they've been able to get help
Mhm.
at a much earlier stage. I think that the shame, when I look
Yes.
back at kind of my time, was that people kind of, they waited till the bitter end, until it was so obvious, before kind of anyone either did anything or
Mhm.
they asked for help. Nowadays, one of the things I kind of rejoice in is when people kind of get help at a much earlier stage.
Mhm.
And
Mhm.
I think we've done a lot as a field to make treatment much more kind of attractive. I kind of
Mhm.
would like to think that
Mm.
kind of treatment would be something that someone would reward themselves with, whereas it used to be threatened as a kind of punishment, that you're going to
Exactly.
go and do 28 days if you don't stop drinking or whatever.
Yes.
That's how could that ever work? It's
Yeah.
got to be that people feel like this is a kind of nourishing um experience coming
Mhm.
to treatment, and it's really going to give us the help.
Mhm.
Because just telling me you're going to take away what works, the kind of drink and drugs, or whatever
Yeah.
the issue is, and then just leave me with kind of raw feelings and
Mhm.
that's just torture. It's like a
Mm.
double torture. So yeah, a long answer again. Sorry, Abdullah.
No, no, it's fine. I'm glad to listen to you, but we will get back to that topic. But if we get back to your childhood, you mentioned something. You started with self-harm.
Mhm.
How did you get into, just for someone to understand, what emotional state were you been, and have you been, and why?
I mean, it's really difficult to understand. I mean, and it's really difficult for me to put
Mm.
myself back into that um, mind space. Really, I
Mm-hmm.
mean, I I I think I was, I think I'm kind of, kind of ASD and kind of um, quite
Mm-hmm.
obviously a bit sort of aspy with how I am generally.
Mm-hmm.
Um, and so I think there were kind of like this whole smorgasbord of things that were going on. I think, I think there were difficulties in our kind of family circumstances, in as much as, kind of our life was up and down a lot.
Mm-hmm.
Um, my parents were kind of away a lot. My dad was quite kind of angry back in the day. He won't mind me saying, I'm sure.
Mm-hmm.
And and so I've got this kind of absent, distant,
Mm-hmm.
angry, relationship. But at the same time, some tremendous privileges. I mean, he
Mm-hmm.
was um, properly mad and flamboyant, and there were some wonderful things about that. He would just go
Yes.
off and kind of like buy a farm, and so we'd go down and live on a farm, or he'd buy a
Mm.
house in Wales, and we'd go and travel down to Wales, five of us in an Afghan hound. It was the
Mm-hmm.
70s, and so there were some magical experiences in there, but also just some real weirdness and difficulties and a lot of moving around and poor biology. I mean, I kind of think,
Mm-hmm.
my grandfather on my mother's side suicided, so we've got kind of a strong depressive
Mm.
line kind of going, lots of addiction, compulsive behaviors, lots
Okay.
of kind of traumas, And then for my parents, they both had really, really traumatic upbringings. I mean, my dad he's written about it a lot, so I'm not
Mm-hmm.
kind of breaching his confidentiality or anything here, but I mean, he had a really, really brutal
Mm.
childhood. And as genuinely loving as I believe he is, I mean, he absolutely is. I think it must have had,
Mm-hmm.
a terrible kind of impact on kind of how he could relate to us and
Mm-hmm.
what it was like. So, but that's the problem with mental health. It's not this one thing. It's not the trauma. It's not the
Mm.
kind of biology. It's not kind of society. It's this smorgasbord of different things that kind of
Mm.
come together,
Yes.
that kind of underlie the problems, if you see
Yes.
what I mean. So, but I mean, yeah. So I what I kind of remember was first of all discovering drink, being very depressed. Really, it was kind of as much. I mean, I felt suicidal, which is weird to
Mm.
imagine because I've seen my own children grow up, and to imagine somebody of my age then
Yeah.
feeling like they wanted to die and then kind
Mm.
of cutting myself. Um, it wasn't just, I mean, then obviously there's the kind of process of cutting and but there was also what I found weirder is that kind of suicidal intent. And much later
Mm.
in life, I have, chronic depressive episodes where I have tried to
Mm-hmm.
take my life. So I kind of understand. But I mean, to
Mm.
have my first one kind of that young and be
Yes.
self-harming and then drinking and then, as soon as anything came along that would work as
Mm.
an anesthetic. And I think also kind of that bit of going to all these different schools, not fitting in, being socially awkward as I am.
Rejected. Mm.
Yeah, and the kind of bullying. And I also had a massive operation on my leg when I was a kid. I was only about 9. I spent a year in hospital, and that whole thing was kind of really traumatic
Mm.
as well. So it's just like you can just see this kind of cluster of things. And then straight away, kind of at 12 or whatever it is, to go to boarding school.
Mm-hmm.
And this whole kind of boarding school syndrome that they talk about, kind of like,
Exactly.
um, and for me, it was kind of, there was again another mixed experience, because I think there were incredible privileges.
Mm-hmm.
It was close to here, beautiful, similar sort of sandstone buildings and amazing opportunities to do things. But also, it was really brutal. I mean, it was a
Mm.
brutal place, and just and we were all kind of like, I was homesick. I didn't like being
Yeah.
away. I found it weird being in this institution. And
Mm-hmm.
yeah, so I had a really bad experience with that.
Mm.
And I have to be careful of all of that as a therapist because, I've got lots of friends who went to boarding school and they had the best time of their lives. And
Mm-hmm.
I believe them, I mean, it's just that my experience was incredibly difficult
Mm.
and I found it really, really sort of
Mm.
traumatizing. And then kind of weirdly coming out of that at 16 when I got thrown out and I went to the tutorial college in London, I had a kind of good year. And that's kind of
Mm.
typical story for people who get into addiction problems because
Yes.
kind of getting into the drugs more at kind of, 17 in London, I was doing reasonably well in the city and, just
Mm.
that whole kind of, but it was madness. I mean, it was genuinely
Yes.
Wolf of Wall Street. I mean, they literally got that film right. It was that mad. Um, but kind of there was a weird period there where I was sort of in balance, where the drugs
Mm.
were working,
Mm-hmm.
where I felt like they were coping with the mess underneath
Yeah.
and I was functioning in a weird way. Um, and then, of course, it all falls apart again. So
Yes.
that's the kind of, but people kind of probably don't understand with
Mm.
addiction that there's a period where it kind of really works.
Mm. For how
And
long did it work for you?
I mean, on and off, I want to say a couple of good years, which doesn't sound like a lot, does
Yeah.
it? But it was. I mean, it was a lot, and it
Mm.
did make a difference to that kind of real kind of pain and awkwardness that I felt
Mm-hmm.
to have 2 good years where, yeah. I mean, I regret those 2 years, ironically,
Mm.
because I'm trying to remember the psychiatrist who said that being an alcoholic is like having a frontal lobotomy, and that um kind of there's a kind of a disconnect from our emotions and our kind of morality, I
Mm-hmm.
suppose, that means that, I mean, it leaves me with behavior that I feel very ashamed about. I mean, that
Mm-hmm.
whole thing of working in the city and the Wolf of Wall Street is, it's funny, but it's also hideous.
Yes.
Do you know what I mean? So there's kind of, I've got very mixed emotions about all of that. And when I say it was working for me, it was working for me on that level, but it actually took me further away, I think, from who I really am, or who
Mm-hmm.
I would like to think I am.
Mm-hmm.
Do you know what I mean?
Yes. So you were also very young when you started with the addiction. What sense of relief or did you had at that time?
I mean, like even at that time, at the younger
Yeah.
ages, I mean, I think it was like, it was magical. I mean, I
Mm-hmm.
think I hear a lot of other people kind of saying that thing that, or actually, I was talking with somebody just before this show, and they were saying that kind of, their first experience, they were kind of like exposed to weed, and they thought,
Mm-hmm.
God, this is awful. And it's strange because for me, my first experience of kind of every drug, whether it was alcohol, weed, or kind of coke, heroin, whatever, was always, this is magical. I mean, and
Mm.
I think that's really interesting because I think people who don't have that kind of addiction
Mm-hmm.
profile, my wife, for example, she'll have a kind of couple of glasses of wine or something, and then she says, "I've reached my limit. I don't, don't want to,
Yes.
I don't want to feel out of control. I hate that feeling of feeling." And I'm thinking, that's the whole point.
Yeah.
So I think there's a kind of an experientially different experience that we have when we first kind of, or whenever we kind of experience those
Mm-hmm.
substances or behaviors. So I mean, at that very
Mm-hmm.
young age, it was transformative.
Mm-hmm.
It kind of took away those difficult feelings and it made me less incredibly sort of socially awkward and stuff.
Mm-hmm.
So it was magic. If I could have that without the kind of loss of myself
Yes.
that went with it, I'd be in heaven. But um and if I have to make a choice,
Mm-hmm.
I kind of I'll do without and
Mm-hmm.
work on that kind of awkwardness in kind of other ways, basically.
Yes. Well, what do you mean with socially awkward? So how have you been there socially with other people?
I really like meeting people kind of one-on-one or in
Mm-hmm.
small groups so I can function as a therapist. But
Yes.
if I get out into a kind of wider scenario, I feel really awkward. I
Mm-hmm.
mean, I think it's one of those awful things where because I'm kind of feeling anxious and awkward,
Mm-hmm.
my anxiety kind of makes me say stupid things.
Mm-hmm.
And then I remember all the stupid things I've said because I'm anxious. And it's just like this vicious cycle with
Cycle.
it.
Yes. Yes.
But I'm kind of like, you know, say I'm kind of, neurodivergent, then
Mm-hmm.
I'm kind of okay with that, if that makes sense. I've kind of adapted my life.
Mm-hmm.
My wife kind of tolerates it as
Mm-hmm.
well. She kind of knows the kind of limitations in a sense of what I can
Mm-hmm.
do and what I'm comfortable with, and I'll go along as much as I can
Mm-hmm.
to show willing. It's interesting. I think, kind of earlier on, we always used to think about how we were going to kind of overcome our kind of limitations,
Mm-hmm.
and nowadays I think we think more, actually, we're just wired differently. So let's adapt our life to how we are rather
Mm-hmm.
than, do you know what I mean? So I think,
Yes.
around that, I'm more forgiving of my quirkiness and
Mm-hmm. You
oddnesses,
come to accept it,
and I
and
accept them, and I've kind of built a life that kind of works around
mm-hmm.
that, and I'll do my bit. I've
Mm-hmm.
been at this conference. It's just sort of like, the nightmare scenario for me, kind of like hordes of people and stuff.
You're doing good.
Thank you, thank you. So I will do my kind of bit, but
Mm-hmm.
it's not my happy
Yes.
place.
You had some depressive
Mm.
episodes. At what age was that?
I mean, so obviously, well, not obviously, but I would say that kind of first one was very young, wasn't
Mm.
it? Kind of like that earliest episode, and I hadn't realised that
That's
was
what,
what it
yeah.
was. Um, and then I guess, I've had them on and off.
Mm-hmm.
I had a particularly terrible one, kind of probably about, weirdly, 10 or 15 years into recovery. And
Mm-hmm.
I mean, there was a trigger, which was around kind of relationships, but I don't think this stuff, well, is and isn't about triggers. I
Mm-hmm.
think there's kind of like, there is that kind of vulnerability and frailty. I mean, sort of when people have, one mental health diagnosis by kind of 18, which I at
Mm-hmm.
least had, um, there's a really high percentage chance that they're going to have a
Mm-hmm.
secondary or a tertiary kind of diagnosis,
Yes.
or second primary diagnosis, really, later on in life, by the time they're sort of 50. And I
Mm-hmm.
just lived out that stereotype. I kind of had these manifestations,
Mm-hmm.
kind of
Mm-hmm.
early on through kind of addiction
Mm-hmm.
and the social anxiety and all that kind of stuff. And then later on, the kind of massive depression came on. I mean, roll on my 60s. I'm 59 now, so I'm going to
Yeah.
become psychotic in my 60s probably. I mean,
Mm-hmm.
but I'm sort of weirdly okay with that, in the sense that I'm frustrated by the kind of
Mm-hmm.
simplistic narrative of mental health that, kind of, I had this terrible thing that caused my problem. I then had a treatment episode and I turned my
Mm.
life around, and everything was kind of rosy
Yeah.
after that.
Yeah.
And it's just think, okay, great. I mean,
Mm.
maybe people are doing
It
that,
works
but
for some.
it's not my reality, and it's
Mm-hmm.
not most of the people that I see. Most of the people that I see have complex lives, complex things happen, and that general vulnerability kind of remains and
Mm-hmm.
can be kind of activated in other ways.
Mm-hmm.
Um, Now that's, kind of awful in one sense, but
Mm.
it also just is, and I'd rather people just kind of tell me the
Yeah.
truth and work with that.
Yeah.
So,
Come to term. That's a reality.
mm.
Mm. How did you get into recovery or to start treatment in the first place?
The easy answer was that it was offered to me, but that's actually also quite important,
Mm-hmm.
because I think I think every time somebody's got a problem, they're in kind of two states of mind with it. There's
Mm.
the kind of part of them that's functioning and kind of wants to continue, and then there's the part of them that wants help. And
Mm-hmm.
those two parts are kind of flowing every day.
Mm-hmm.
Um, and so I don't think it's about kind of, so I think one of the most important things is to make the offer of treatment available
Mm-hmm.
and not necessarily push someone into it straight away. That's why I'm
Mm-hmm.
saying, kind of, with the next generation, I like this idea that kind of my family know that if they want help, they can
Mm.
get it, they can dip their toe in the water, And if they don't and they don't need it, then that's fine too. But it's
Yes.
that general acceptance. So I think one of the things I think about is that at least it was offered to me, and
Mm-hmm.
I was, for some weird reason, on a kind of whatever it was, a Thursday afternoon or something, I just thought, hey, maybe I'd go. And
Mm-hmm.
like, and I think it's as probably as banal as that in a sense. And I think, I've kind of been through a lot of kind of recovery groups and self-help
Mm-hmm.
groups, and there's very often a kind of narrative of a kind of a rock bottom that people had to get to this
Mm-hmm.
sort of mythical place that was so awful that they couldn't go on. And I kind of think that could have been anywhere. That
Yes.
could have been when I was 11. That could have been when I was 15. That could have been when I was 17 and 23. Could have been when I was 40. I mean,
Mm-hmm.
why was it that it happened to be with that one time at 17 and then again at 23?
Mm-hmm.
Why particularly? And I think the most important part of that is that I had the understanding that it was available. It was actually an option that was open to me, and there was an understanding around. So
Mm-hmm.
I think it's more about kind of making the possibility of treatment interesting and inviting
Mm-hmm.
and available than it is about kind of having somebody come to a particular point, because that could have been anywhere,
Yes. So it was not an intervention, and it was really an offer,
Yeah,
an
I mean,
invitation
yeah,
to
I mean, I
do.
laugh because I remember kind of
Yeah.
like my parents did do kind of like an early model of intervention, if you think about it, when they said,
Mm-hmm.
you can't stay in our house if you use drugs.
Yeah.
And I said, oh, you need to stop imposing your white middle class values on me. I'm kind of like,
Yeah. Yes.
I'm out of here. I consider myself an orphan. I remember it was just like really dramatic, but
Mm-hmm.
it's like, I think that's interesting because back in the day there were those kind of Johnson model interventions where it
Mm-hmm.
was, there was it's probably a disservice to Vernon Johnson because what he meant was to have a kind of systemic supportive
Mm-hmm.
meeting, but the way it got manipulated by the industry was to
Mm-hmm.
become this coercive, bullying
Yeah.
kind of
Ultimatum.
ultimatum. And
Mm-hmm.
I think that was really, well, it wasn't actually the original intention, and it messed it up a
Mm-hmm.
lot. And I much prefer, Dr. Judith Landau and the
Mm-hmm.
Arise model. So I'm like a
Yes.
huge fan of hers, and I
Mm-hmm.
think the way that she works, kind of understanding kind of mental health problems and addiction as part of a kind of systemic problem, and
Mm-hmm.
recognizing that kind of all of the family are in a dance and are co-contributors to that.
Right.
There isn't a kind of designated sick person,
Yes.
um, and looking at a kind of crisis like this as an opportunity for the whole family to heal.
Mm-hmm.
I just think that's a really lovely,
Mm-hmm.
and drawing on the resources of the family and the culture of the family, to aid that healing. It's really her kind
Yes.
of her kind of idea, and I love that, and I think
Mm-hmm.
that's
Mm-hmm.
a much more effective way of kind of
Mm-hmm.
helping people than the kind of parodied kind of
Yeah.
letter writing kind of thing. I get the intent. The intent was good there, but it quite often just ended up as being a bullying. And then you kind of like if you've
Mm-hmm.
lost the person like they lost me, I
Mm-hmm.
was out of there. It wasn't my only option. I went and sofa surfed for a bit, and I got a job in the city,
Mm.
and
You were
I think
functioning that time,
I was
as you said.
dysfunctioning very well. The thing is that it's a shame though, because I do feel like there must have been always that bit of me that was really, really hurt and really unhappy
Mm-hmm.
that would have been amenable. I like to think. I mean, God, I don't know. I don't know who I was. So
Mm-hmm.
maybe I couldn't have been. But I'd like to think. I mean, that's how I would like to
Mm-hmm.
approach other people. I would like to sort of try to see how we could offer that help in the most kind of acceptable way
Mm-hmm.
as soon as possible, um, and get it in a lot earlier. I mean, it sounds like
Yes.
a good thing that I got into kind of treatment at 23, but then if you look at the kind of catastrophe of my teenage years and the kind of
Mm.
the price in a way I have to pay
Yeah.
for that,
How
I
could
would
it?
love it if there would have been help when I was like
Yeah.
10, 11, 12.
Yeah. But you were in a different state of awareness,
Very much so, yeah.
and cognitive possibility to regulate your emotions and all together. So
Hmm.
sometimes it just needs time, the right time to arrive. And I understand that um, that families need to heal as a systemic
Yeah.
system,
Yeah.
but it's difficult to realize that it's not just that one person who's bringing that trouble into the family
100%.
by consuming and so on, that it can be also me affecting that. And so this self-realization within that community is important too.
Very much so.
Um,
I mean, and you could say also broaden it out to the kind of the culture, the sort of the
mm,
subculture, and then the wider culture. And I think that's really important. Trying
mhm,
to find a way of kind of,
mhm,
I think if you could work in the family, let's just stay with that. The kind of amount of, yeah, if you could help healing within a family, that's the
mhm,
gift that keeps on giving.
mhm,
If you've got a kid in that family that's going to school, you'd love to think that the school could do great things.
mhm,
But the truth is, if they're coming back and they're sleeping and their primary attachment is to a kind of dysfunctional state,
mhm,
it's just like, it's really unfair. It's really I feel like the schools get blamed and
mhm,
lots of kind of bodies get blamed when actually, you know, really the healing should be focused on helping the family first.
mhm,
And then if
mhm.
you help the family, everything else is kind of going to flow out from that. And if you can help the family and you can help the kind of the subculture locally,
Mhm.
the connections that the family have with other people.
You have to work with the family,
Yeah.
because if we just work isolated with one person and this person would go back to a family system, whatever environment he lives in,
Hmm.
mm, so the triggers are there. The
100%.
system is still
Yeah.
around. So falling back, relapse is highly problematic.
Yeah.
Yeah.
Yeah. I mean, and it's also surprising that there's a kind of behavioral element to it
Mm,
that kind of, even though my behaviors were really dysfunctional, they'd also become a habit, and they were
mhm,
a groove that I was in, and it was a groove that I was comfortable in, weirdly.
mhm,
And actually trying to be in recovery or kind of take a new path, it's so difficult because there is that groove that I kind of naturally kind
mm,
of want to go back into. And actually, that was one of the big realizations that I had that was different between the first time I had those treatment
mhm,
experiences at 17 and 23.
mhm,
So at 17, I kind of thought, really, I just want to take the drinking and drugs out of the picture.
mm.
And then, I'm still going to kind of go to the pub and drink orange juices. And there's only so many orange juices you can drink in a pub back in those drinking days.
Mhm,
Um, and kind of like I could build a great joint, and kind of like I thought this is an art. I'm not going to
mm,
waste this being in recovery. I'm going to build
mm.
joints for other people and kind of hang out in all the same clubs and just like really dysfunctional lifestyle, but not drink
Yes.
and drug, which is,
Mm,
now I think about it, just like the maddest
mhm,
endeavor. Um, but the big difference between that kind of first attempt at recovery and the second one was, the second one I did want to make a much
mm,
bigger, more kind of holistic change. I wanted to, not what I would, yeah, I wouldn't recommend that everybody makes quite so many dramatic changes, but I wanted to kind of, I didn't want to
mhm,
carry on in that career in the city. I wanted to
mhm,
go and do something else. I wanted to I suppose I had a vision that I wanted to get back a lot of the things that
mm.
I felt my addiction had taken from me. So things like my education and
Yes.
culture, and it was this lovely coincidence. Well, maybe not a coincidence, but it was a lovely coming together, that kind of early recovery at 23, because I was wanting to live a kind of a new life, and I
Mm,
was kind of open-minded, and that's a cliched term, but I was adventurous, and I wanted to try out all these things that I
mhm,
felt that my addiction had stolen from me, like, kind of, education and culture and all the
mhm,
rest of it. And I said to myself, I'm going to go and I'm going to explore all of these things and see what I really feel about them. So I put
mhm,
myself into education. I kind of explored art and culture, and with an open mind went to ballet and
mhm.
realized I still don't like ballet. But found lots of other things like
Yes.
opera, that I was kind of really not open-minded to, before. And I kind of think there is that thing
Mm,
about people with addiction that kind of there's a kind of one of the character traits is an openness to experience, and that's one of the things that kind of gets us into trouble. But it's also a virtue
Mm-hmm.
if we are kind of open to experiences and
Mm-hmm.
we're not stuck in the kind of groove of addiction, then actually there's a really exciting, amazing kind
Mm.
of world. And that kind of passion was like,
Yes.
I suppose, what other people kind of would describe as their kind of spiritual kind of awakening. I mean,
Mm-hmm.
that was kind of a similar thing for me in just having those amazing
Yeah.
experiences and kind of, yeah. And that's kind of never
Mm-hmm.
stopped, that kind of
Mm-hmm.
curiousness and
Yeah, curiousness, the
mm,
passion, or to see that the future has something positive to give.
yeah.
That's where you can turn. There is always this, let's say, understanding of someone in an addiction or alcohol addiction that, yeah, I can control it. I
Mhm.
will detox, I will be out of it, but I can still control it. So how was it for you at that time? Yeah, you mentioned that you wanted to control in some or the
Yeah.
other way, but would it be recommended to start slow, to introduce into treatment in a treatment facility, um, without having this big need to change completely one's life?
So do you mean like not stopping drinking, or do you mean
Yes, to introduce someone
uh,
into, because if I would, for example, if I'm contacted by someone, yeah, but I want to, if I would tell these people, look, you will not be able to drink forever,
yeah, I
it
get you.
would it would
Okay.
destroy them, and they would
Yeah.
not be open to go into treatment.
Yeah.
So where,
Well, I
what would you
think,
communicate?
I mean, I think there's a lot of discussions to be had about that particular point and coming into an
Mm,
abstinence-based clinic, and I think that you can say to people, well, don't kind of sort of promise forever. Try
mm,
try for a couple of weeks, see if you feel better. I mean, if you feel
mm,
worse, you go back.
mm.
There's that whole kind of line of thought
Yes.
that's been around forever. But there's another modality which I think is more interesting, which is a model that I kind of came across in Malta. I want to say about 25 years ago or something. It's a
Mm-hmm.
clinic called Caritas, to give credit where it's due. And what I saw them do there really changed my thinking about
Mm-hmm.
addiction, because they had a kind of set of counselors who were kind of outreach workers,
Mm-hmm.
and they would go into the parks. Malta's quite a small place,
Mm-hmm.
so it's kind of
Yeah.
easy for everything to be reachable. So they'd have therapists that would go out into the park, and they would kind of be working with people who were kind of quite often homeless,
Mm-hmm.
kind of uh, opiate addicts typically, and they had a kind of harm minimization approach. So the
Mm.
idea would be, can we bring you clean needles? Can we,
Yes.
whatever we can do to make your using safe? But they would develop a relationship through that, and they say,
Mm.
there's a drop-in center around the corner, the shooting gallery or whatever. You can go and use more safely there if you go there.
Mm-hmm.
And then when they would go there, they'd be met by somebody who would kind of, meet them and support them there.
Mm-hmm.
And then they'd be saying, but we've also got like a detox unit around the corner if
Yeah.
if you ever fancy giving that a go.
Yes.
And so then people might go and try the
Mm-hmm.
detox. They then had a rehab, they had a
Yes.
halfway house, they had a unit in the prisons.
Okay.
I mean,
Live
it
offer
was genius.
options.
It was, well, this is the
Yes.
clever thing. What I thought was genius about it wasn't just those options. It was more the mentality that if somebody kind of got to the detox or got to
Mm-hmm.
the rehab and then relapsed,
Mm-hmm.
they'd go back and be met by
Mm-hmm.
the people in the park again.
Mm-hmm.
And the guys in the park wouldn't be kind of humiliating them. They'd be like, oh, great to
Mm.
see you. How you doing? You're in the detox here. Did you know James there, or John, or how did you
Yeah.
get on? There'd be like a relationship that would just
Mm-hmm.
continue.
Mm-hmm.
And so you could kind of conceive of the kind of treatment model as being an elevator that's constantly trying to kind
Yes.
of pull people up. And they might tumble down a couple of steps,
Yeah.
but they're immediately caught and kind
Yeah.
of brought back up again.
Yeah.
And there's been this really weird false dichotomy between harm minimization and abstinence in
Mm-hmm.
our field for this last kind of 20
Mm-hmm.
years. Um, and it seems super weird because it feels to me like it's all part of a continuum.
Mm-hmm.
I think if you were to be critical of kind of the lot who are in the kind of abstinence camp, it's that they're not accessible enough to
Mm-hmm.
people. And my critique to the people who are doing the harm minimization is that they don't have a high enough aspiration. That's controversial to say, but you know what I mean? The point about joining them up, and I would love it if people in clinics could work in kind of community settings and outreach, and the people in the outreach could work in clinics for a bit to sort of swap seats and get experience of the possibility to reach somebody and inspire them when you've got very little to kind of work with, but also, you know, the inspiration when you're working with people who've been able to get abstinence, and the lack of any moral judgment of where people are on that spectrum. It's about kind of having that elevator kind of, or escalator kind of metaphor of you're just always wanting to kind of pull people up and through.
Yes. And the beauty about it is also not that it's a one-way street. So it can go both ways, and to normalize that understanding of, okay, that's fine. Don't be judged. Don't be, you can try again.
Exactly that. Well, you're reminding me of kind of like treatment from kind of sort of 25, 30 years ago, when it was so regimented and it was so rigid, and it was all about, you know, kind of, it's all going to be jails, institutions, and death if you leave. And kind of, if you leave, you're clearly not ready. I mean, that was a nonsense concept, wasn't it? And kind of like, there'd be limitations on the time before you can come back to treatment. You can't come back. Honestly, this used to happen. I mean, it probably all sounds bonkers now. It was bonkers. But people would be told that. And the treatment itself was very coercive. And there's this kind of weird thing about that, where kind of there were a lot of people, because a lot of the treatment centers were kind of born out of the concept house mentality, therapeutic communities. And with everything, there's always like a positive and a negative. And there was a lovely aspect of community that came from therapeutic community, but also inherently in the structure of kind of clinics. Have you come across Philip Zimbardo's prison studies, the Stanford prison studies? So basically, he's a really interesting psychologist in UCLA, and he had this psychology study where he wanted to see if he randomly allocated students to be prison officers or prisoners. He would see how they would kind of evolve, and it was all quite elaborate. He had a, you know, cop car that he would go and pick them up in, and the guys had uniforms and stuff. And he ended up, get to the punchline, he basically had to abandon the study after 3 days because the guards became so abusive. And what he was trying to show is that when you're in that kind of position of authority, it tends to abuse. And if you're not careful, with the greatest, I'd like to think prisons have good intent, but I mean, even in a clinic where you imagine that they have good intent, it does lead to a lot of abuse and coercion. And that was a really dark part of the kind of treatment world's history. That I can see what kind of where they were transitioning from having nothing to having kind of these treatment facilities, but it wasn't all great. There was kind of like, there was a dark side to that too that needed to be, that I really hope has changed. But I mean, it's a subconscious kind of, I mean, you could look at it in transactional analysis terms of the kind of, you know, the parent, adult, child ego states that we all have, and we oscillate between those within a conversation, within an afternoon. And kind of in a parent ego state, we'll be kind of, you know, giving instructions. In an adult ego state, hopefully we're having a discussion like this. And then in a child ego state, you know, we might be having a laugh. So I mean, even in this conversation, we might go through those different ego states. And the point about TA is that they kind of believe that, you know, it works really well when you're having parent or adult child conversation. But it's like kind of don't cross the beams in Ghostbusters. They like the kind of top diagonal parent to child, but you can't really do child adult or adult parent. That doesn't really work. It tends to either lock into those three or the diagonals. Now, the common dynamic in a clinic, anywhere where you've got a position of kind of quasi authority, you're going to tend subconsciously to be in a kind of parent ego state if you're not careful. And when we're vulnerable and we're clients, we are going to tend subconsciously to kind of want to go into a kind of child ego state. So we're coming into a clinic and we're going to evoke a kind of parental authoritarian kind of
Right.
tendency. And I think in clinics, clinicians have to be kind of aware of that.
Yes, I like
And
that view.
yeah, and kind of like stand back and kind of go, hang on a
Mm-hmm.
second, how do I stay in adult? Because if you keep meeting people, generally as
Mm-hmm.
adult or as child, you can have fun with people and stuff. But if you're in that kind of adult state, you're tending to pull people back up if they are feeling in a kind of
Mm-hmm.
vulnerable kind of child ego state. If you put it in that transactional terms, you're more likely to pull them up into adult. Whereas if you speak to them in the kind of,
Mm-hmm.
so say somebody's kind of deliberately provocative, kind of, if you go into that kind of authoritarian parent, you're just going to reinforce that kind
Yes.
of that state. Whereas if you can try and hold the adult ego state, so it's a
Mm-hmm.
long way around to saying that, but it's just to say that inherently
Mm-hmm.
clinics kind of subconsciously fall into that kind of risk of doing that. And
Mm-hmm.
it's got to be kind of quite a conscious process for the team to not fall into
Yes.
repeating the kind of Zimbardo prison experiments, because that's how I would explain what happened
Yeah.
in kind of like 1980s,
Yes. That's
treatment centers.
such a beautiful explanation, I must say. And I think the door gate to this is compassion
Yeah.
throughout the organization.
Yeah.
But it gets difficult once the client wants to be more the parent ego uh, dynamic, especially if we work with, let's say, high net worths
Yeah.
or celebrities and known people.
Yeah.
So there is also a difficulty how to keep this compassion in a way that, okay, it's still the client and it's still someone who is in need.
Yeah, you made me think of a couple of other things. I mean, yes, definitely there's a kind of uh, there's a risk that somebody might be kind of approaching you from that kind of parent
Mm,
ego state, and kind of it's important to kind of try and not go to parent as well and
mhm,
just be kind of authoritarian back, but hold the kind of adult, or not be the child and be
mhm,
meek. It's like holding that kind of adult place if we do it in the TA terms. But also there's always that super interesting thing, I think, in therapy, that how you manage those difficult kind of engagements when a client kind of either falls in love with you or hates you,
mm,
um, that's really, really rich therapeutic
mhm,
kind of material, and kind of how you manage that and how you help somebody through that. I mean, I would say if you're, I mean, hopefully it's not a hate,
mhm.
but if a kind of client doesn't ever have any difficult feelings towards you as a therapist, you're
Yes.
probably not doing therapy, one way
Right.
or the other. So um, I kind of think that's part of the process, and how we manage that and how we
Mm,
handle that as
mhm,
therapists is really critical to how they kind of, yeah, how they survive it and how they evolve, because we're going to be feeling
mm,
probably quite a lot of kind of typical uh, situations in their world,
mhm.
um, and they're probably not aware that we are experiencing it as difficultly as we
Mm,
are. I mean, genuinely, it might be quite a kind of subconscious level,
mhm,
but that's the gig. That's our job, is to kind of be able to hold that and hold the space, and then be able to help somebody kind of work through that. So I think I'm going away from TA now and kind of into a different kind of frame of reference, but I think it's a really
mhm.
interesting one,
Yeah.
how to kind of hold that space and constantly hold a kind of therapeutic frame.
Yes.
And that's really tricky in a kind of broader clinic,
Mm,
where, I mean, every member of the
mhm,
team is crucial and is part of the therapeutic
yeah.
network. And but they have, different levels of experience, and kind of, if they're experiencing like a really difficult period,
Mhm,
supporting them with that and kind
mhm,
of helping them not be kind of reactive, but to process and
mhm.
understand the psychological process that's going on here, is kind of key to helping the team kind of grow as a therapeutic kind of organ. You
Yes.
really want the whole clinic
Yes.
to be one big kind of therapeutic um,
evolving and
interface.
learning.
Yeah.
How do you do this in your daily practice? Like now, historically, that the whole team can grow as such.
I mean, I think it's kind of really kind of having a
Mm,
lot of, I think it's having a kind of culture
mm,
where I value people based on the positive impact that I see them having on the clients. I'm
mm-hmm,
making one judgment. Does this team member help our clients,
mm-hmm,
or are they not?
mm,
And I'm not any respecter for their age, their gender, their profession.
mm-hmm,
I don't care about the hierarchy. I just care, how does this person create the hold the kind of therapeutic space,
mm-hmm,
and that, again, going back to my own experiences when I was in treatment, it was very often kind of housekeeping or the gardeners that I got
mm,
on better. I mean, the
yeah.
therapists all spoke gobbledygook and this kind of weird therapy speak.
They had no agenda
Yeah,
for you,
yeah,
probably. Yeah.
exactly. So I really see the value of the kind of the whole team,
Mm-hmm,
and our kind of housekeeping and our, at the Cardinal clinic, or at Promise, they are so important to the whole
mm,
therapeutic place. Now, it's really hard to kind of be, working in the kitchen and then experiencing quite sort of difficult
mm,
situations. And so it kind of takes a certain kind of person that wants to work in a psychiatric hospital, even in the kind of, housekeeping or kitchen.
mm-hmm,
Um, but when they work well and when they have a passion for it as well, the impact that they can have is greater than the
mm,
therapist, honestly.
yeah.
They really, I mean, and they're, yeah. So
Mm-hmm,
that's the art of our world, isn't it? Is trying
yes.
to, and that's the interesting part of our world, is kind of trying to hold that kind of whole
Mm-hmm,
team together, to hold a common vision, and to work with the same frame
mm-hmm,
set. I mean,
mm-hmm,
and look, I'm realist. It doesn't it doesn't always work out like that.
yes.
Um, and people kind of groove into it, or they don't fit in and they have to groove
Yes.
out. But that's really the model. I think the
Mm-hmm,
model is that the whole clinic is the therapeutic kind of intent,
yes.
and yeah, vehicle.
I agree with you. Um, it's just you said one person if it's helping this client or the clients,
Yeah.
but it can be different. It can be having much more nuances. One client responds to one person, but the
Yeah.
same person would be not working well with another. So
Definitely.
we cannot just reflect all on this employee or part this therapeutic clinic and concept. So also as an organization, I believe it's important to be there for the staff, for the employees, interacting, whoever this
Hmm.
is,
Hmm.
and help them
Exactly.
process and learn as a team. So
Yes.
like at our facilities, for example, we do supervisions with every
Exactly.
every team member. Every if there has been a struggle, a particular struggle, because every client is different. So we try to work it through and give a chance to the team. So not make it okay, this the client is not making it because of you. It's not about judging, but no, it didn't work now this time with you, and that's fine.
Yeah.
This is because of it didn't work with this one, but it may work with another one.
Absolutely. I mean, I think it's also about kind of, uh, d- not meaning to it to be patronizing at all, because I view the kind of therapeutic team as I would my clients,
Mm-hmm,
and I view my clients as I would my family.
mm-hmm,
Um, so in other words, it's not from a sort of paternalistic,
mm-hmm,
patronizing kind of perspective, but it's one of kind of compassion um, and wish for growth and wish for the best possible
mm-hmm,
outcome. So I kind of think we should be working with our colleagues
mm-hmm,
in the clinic, in whichever departments they are, as kind of co-therapists, and in, like you say, in the sort of supervision. And we should be wanting to see them kind
mm-hmm,
of grow and learn from
mm-hmm.
their experiences, just like we would our
Yeah.
clients like we would our family and like we
Yes.
would ourselves. I mean,
Yes.
really what we're seeing manifested in clinics
Yeah.
is the kind of value system and ecosystem of the
Yeah.
people who kind of work there. And
Mm-hmm.
so, you know, kind of holding that is really important. But another point
Mm.
you made I wanted to come back to was about the necessity for kind of different individuals.
Mm-hmm.
And I think it's really important that there are different characters in a clinic. And when I'm kind of looking to kind of hire people,
Mm-hmm.
I'm always looking for, you know, do I find them interesting, obviously, but, you know, are they well qualified, blah, blah, blah. But also kind of, are they actually bringing something different from their
Mm-hmm.
kind of cultural
Mm-hmm.
experience or that kind of stuff? Because I want them to be different. And I want our clients to know that they will be able to find somebody that they like.
Mm-hmm.
I'm almost certain that they will find somebody that they don't like. And
Mm-hmm.
that's okay with me, because if you've got enough variety of characters,
Yes.
then that's just about who I gel with. And what I
Yes.
want, because people are with us for quite a short period of time, is the best chance of them
Mm-hmm.
finding somebody they like,
Mm-hmm.
because it's so much easier to kind of learn. I mean, do you remember kind of like 20 years ago, people used to kind of bang on in kind of clinics if they made a therapeutic relationship with a therapist and it wasn't going well, and
Mm-hmm.
then there'd be these sort of tedious weeks of why isn't it going well. It's like, who cares why it's not going well? If you don't like that therapist, change the
Yes.
therapist. We haven't got time for that.
Yes.
Find the person that you really like, that
Yeah.
you're inspired by, that you find you want to work with,
Correct.
and work with them. I mean, I don't know, it goes back to like,
Yes.
why was it ever okay for clinics to kind of think that way? But it was really like that. And now it's nonsense. So yeah,
Mm-hmm.
I would want there to be a variety of
Yeah.
characters, and for people to have and literally
Mm-hmm.
have the choice. I mean, we do a thing where we kind of evaluate, it's called feedback informed treatment,
Mm-hmm.
Scott Miller's work in America. But we're literally kind of asking the client at the end of the
Mm-hmm.
session, you know, was the material the right material for you? Was
Mm-hmm.
the, you know, am I the right fit for
Yeah.
you?
Yes.
Is, you know, how are you doing? How are you progressing in
Mm-hmm.
treatment? You know, kind of getting that honest feedback, and which is quite
Yes.
difficult because our clients are by and large lovely and kind of don't want to kind of hurt our feelings if we're not doing a
Yes.
great job. But actually, what we want as therapists is to find exactly the right fit
Mm-hmm.
for them, the right tools, the right therapeutic relationship, and it's okay, you know. I was
Mm-hmm.
like, I want to know
Mm-hmm.
if it's not me. And I'm always kind of going, you know, we were talking about this today, but you know what, I really think, you know, you did really well to talk with peers about somatic experiencing. I think you'd really like the way that he
Mm-hmm.
works. Or have you spoken with Pam about, you know, kind of a psychiatric matter, or, you know,
Yes.
kind of another medication that she's been talking about, you know? And I think that kind of, you know, crossover and the
Mm-hmm.
freedom to kind of move between therapists,
Mm-hmm.
styles of therapy, modalities, professional
Mm-hmm.
disciplines, and to move kind of seamlessly
Mm-hmm.
is the dream. I mean, it's a
Yeah.
really hard thing to
Yes.
manifest,
Yes.
as you and I
No,
both know. But you know, that's
getting authentic feedback is always very difficult while in treatment or at the end of treatment.
absolutely,
But
yeah.
for example, what we do is we ask questions later on,
Hmm.
after a couple of weeks or a couple of months even.
Hmm.
So how has the process been
Yeah,
retrospective
yeah,
to understand or get more and
yeah.
reliable feedback, and to the point of how to handle with the team members to create this therapeutic environment is to be human first.
Yeah,
That's our approach,
yeah,
not just for the clients but for the team members.
yes,
I believe when when something goes wrong in terms of connection to one of the team members, if
mm,
we are there for that person and show compassion and
yeah,
show support and help through that, the next client will profit from that,
100%.
working with this client,
Yeah,
this particular person.
yeah,
And that's how we create compassion. It's not
exactly.
about training, reading,
Yeah,
and
yeah,
the compassion is you have to say that according to a playbook.
yeah. No, exactly that. We are modeling a family,
Mm,
aren't we? And kind of how we are with each other. Um, is exactly what we want to show
Yeah.
our clients. This is how we can be. I mean, with
Mm.
all our foibles as well. I mean,
Mm.
we've got our kind of quirks and idiosyncrasies and fallibility,
Mhm.
and then kind of owning that,
Yes.
and owning, owning the mistakes
Yes.
and is a really important part.
Yeah.
It actually builds trust, ironically,
Yes.
because if somebody can actually, you know, admit where they've gone wrong and is
Mhm.
open to kind of making it right, I trust that
Mhm.
for person a hell of a lot more than
Yeah.
the person who's just kind of covering up or whatever. So
Exactly.
we're modeling in everything we do in
Mm.
the organization, and
Yes.
everything we do in the organization has a
Mhm.
kind of holding effect
Mhm.
for all of the clients as well.
Where have you been for your first treatment?
Promise. I mean, I came to the family firm
You
first.
started a promise.
Yeah, at 17.
Mhm.
Yeah. I mean,
And
Promise started in 1987. It was kind of one of the
yes.
very early
Yes.
kind of centers.
And this worked for you from the first treatment program?
Do you mean like as in my first treatment experience?
Yes.
No, obviously. Sorry, that was the bit we were talking about
In the
earlier, wasn't it? About kind of like I went through for that treatment episode, and I stayed
mm,
sober for a year, or sober and clean for a
yes.
year, but then
Yeah.
I kind of relapsed. And
That was
so,
in the US.
well, no, sorry. So, okay, so the first treatment experience was a kind of promise, and I stayed there
Mm-hmm.
for 2 weeks, but then I walked out. And
Mm.
then my parents sent me straight away to Hazelden, and
US,
I went there for
exactly.
two weeks, and then got thrown out.
Mm-hmm.
And then kind of the thing was, when I came back, I did stay
Mm.
sober and clean for a year.
Mm-hmm.
Difficult terms nowadays to use, but you know what I mean. I was in recovery for a year before I then started using
Mm-hmm.
again.
Mm-hmm.
And the curious thing about that is, actually, I'd love to talk about this because this is, I think, a really important point in our field. Um, I then kind of went back into the cycle of using.
Mm-hmm.
So, did that first treatment episode work? Was it successful or not? I mean, this is the big question.
Yes.
And I'm really inspired by kind of John, do you know, Professor John Kelly at
Mm-hmm.
Harvard? He's a kind of researcher who kind of spends a big focus on addiction. And one of his kind of papers was about um, the period of time that it takes and the process of coming into recovery,
Mm.
because we don't talk about this much as an industry or in the field. And what he kind of showed was, on average, from the first point when somebody has a problem
Mm-hmm.
until they first ask for help, is on average 5 years. And
Mm-hmm.
he then says that on average, from the first time that someone asks for help
Mm-hmm.
until they're able to achieve a year's sobriety is about another 5 years.
Okay.
And then from that point to having a relapse risk that's super low, like the same
Mm.
as the rest of the population, it takes another 5 years. So he said, look, don't be kind of disheartened if you're working
Mm.
in the field and you're in this kind of middle bit where it takes people 5 years from asking
Mm.
for help to achieving it. He said that is part of the kind of process. And I think what he was sort of at pains to say is there's long periods of sobriety in there while people are trying to find the right way of doing it, but they're
Mm.
likely to have quite a few kind of relapse episodes. And so, if you, I don't want to make it about me, but if you
Mm-hmm.
look at my treatment experience, the
Yeah.
first time I asked for help was 17. I then had, reasonably long period of, well, more than a year anyway,
Mm.
and then relapse. And then the kind of final time that I went through treatment was at 23 or so,
Mm-hmm.
5 or 6 years later.
Mm-hmm.
So that is actually bang on the average. Now, the kind of, I suppose, the problem that I have is that kind of treatment seems to be marketed as a kind of, one-off kind of unique experience that is a
Mm.
cure-all. And,
Mm-hmm.
I just think that's
Yeah.
rubbish. I think that people kind of tend to adapt to kind of mental health challenges gradually,
Mm-hmm.
So my first dipping of my toe in the water was that 2 weeks in Kent and then 2 weeks in America. And then, okay, I'm just going to not drink and, carry on as if everything's normal. That was just the first kind of go. And of course, it's frightening that somebody might go back, and it was,
Mm,
you know, awful, the mess I kind of carried on getting into, but it's kind of normal.
yes.
And then the second time that I came back to treatment, it was for me a very different experience because I knew what I didn't want to do, what hadn't
Mm-hmm.
really kind of worked the first time, and I knew I wanted to try something different. So I was kind of amenable. Now, probably in that period of 5 years, I don't think the treatment industry had changed very much.
Yeah.
So it was probably the same, more or less, treatment
Mm-hmm.
experience, but I was in a kind of different frame of mind
Mm-hmm.
and a different stage in my process of coming into recovery. And I think that's what we should kind of understand and acknowledge rather than saying, I don't know. I think people make up a big story about
Mm,
why somebody hasn't been able to achieve recovery and why this particular clinic is going to be the kind of
mm,
cure all and fix all of everything.
mm-hmm.
And I think we're doing everybody a disservice by doing that. I think we should explain more that there is this kind of process and we're going to
Mm,
do all the things that we can do to accelerate that recovery process for people.
yes.
But it is still probably going to be a bumpy ride. And
Mm-hmm.
rather than trying to kind of create a fantasy that treatment is some kind of unique experience, I think it's better to kind of think about what I was talking about. What I hope to do for my
Mm-hmm.
kids is kind of create a culture where people want help and that they enjoy the
Mm,
experience. Enjoys the wrong word, but you know what I mean. They kind of feel that the treatment was actually a reward and it was
yeah.
nourishing and a really good experience, because if they do that, they're going to come back if they do go, you know, get
Mm-hmm.
into further difficulties much sooner, a much earlier stage, and they'll project into recovery much more quickly. But
Yeah.
I don't think we do that very well as a field. I think we kind of
Mm,
set up this kind of
mm.
fantasy that kind of like there's a unique clinical experience that people can have.
What
No,
can we do different?
be honest. I think,
Mm,
that's the kind of underlying, what can I say, foundation, I think, of everything kind of
mm-hmm.
therapeutic. I want to kind of sit with clients and be able to kind of say, look, we're on a journey together where we're kind of
Mm-hmm.
exploring these different treatment modalities.
Mm-hmm.
Please explore it with me. Try different therapies, try different therapists, look at the kind of
Mm-hmm.
research. I know that's kind of probably a bit kind of too geeky to go into too much, but I do think kind of like, you know, there isn't some kind of
Mm.
magic source.
Yeah.
I mean, you know, kind of like, and there and information is more and more easily accessible. I mean, you can use kind of AI
Mm-hmm.
models to say, I've got these symptoms. I was talking with a
Mm.
friend of mine who's got OCD, and she was saying, you know, oh, I don't want to do this and I don't want to do that. I said, well, look, you know, spin up ChatGPT, or actually Grok's slightly better, annoyingly, than ChatGPT, and have a conversation and say,
Mm-hmm.
oh, I've got, you know, OCD and I want a kind of treatment plan. Tell me what the three best evidence treatments are,
Yes.
and then create me a treatment plan for the next 3 weeks based on those.
Mm-hmm.
And I said, kind of see what that gives you. And I
Mm-hmm.
think that's where we should be meeting our clients. We shouldn't be
Mm-hmm.
sort of selling them some kind of sort of secret sauce. There isn't any
Mm.
secret sauce. There's evidence, there's treatments, there's
Yes.
good quality professionals, and we
Mm.
share it. Do you know what I mean? I think, so yeah, that's my little
Mm-hmm.
thing about the profession kind of, or the field now, that might bugbear a bit.
Mm.
I just think,
No, I get your point, but it's difficult because on the one hand side you could normalize relapse. Yeah, it's part of the process, but then kind of yeah, um,
isn't it?
yeah. That's the question. So, is it the right direction just to normalize it, and what would it make with someone who who is then in recovery? Yeah, yeah. I can have it's part of the
No, I
no.
know. I love this discussion because it kind of comes up so much. And the
Yeah.
funny thing is that, you know, because we used to have it a long time ago, kind of in the clinic, there was this thing about kind of, well, if somebody relapsed, There was always this really weird set of judgments that went with it as well. There was like, did one person bring down another? There was always
Mm,
somebody to blame, and there was like a
mhm,
nonsense that kind of went on around it. I mean, the reality is, if somebody's kind of mentally unwell and they have a lapse, I mean, if we really understand
mm,
addiction as mental illness, which this is where I see it,
yes.
then if somebody became more depressed in the middle of treatment,
Mhm,
would you throw them out?
mm,
Or if somebody became more psychotic, surely you would just treat that.
mhm,
Um, and it's like, I've never seen, well, anybody who's got a genuine addiction problem, I've never seen them go out and be a great
mm,
advert for addiction.
yes.
If they
Yes.
go out, they're, I mean, sadly, generally smashing
Mhm,
themselves up with it. They're not going out for fun. I mean, that's what
mhm,
people who
yeah.
don't have an addiction problem probably don't get about addiction.
Yes.
This isn't what we're doing for a laugh. We're kind of almost self-harming with it,
Mm,
with addiction. And, kind of, so I kind of think if that
mm,
person, having had that experience of relapsing,
mhm,
wants to come back in, realizes that that was a mistake and work
yes.
forward from that, I would work with it. I mean, I remember being in a group
Mm.
in Kent. Sorry, I was just finishing this. Where kind of like these trainees came in and they said to me, and it was kind of like largely a group of people with alcohol problems at that time. And the trainee said, "Well, look, if you know, would you just work with it?" I mean, so opened the group I was taking, and I said, "Look, does everybody know that if they went and had a drink, I would carry on working with them?"
Mhm,
And they're like, "Yeah."
mm,
And I said, "And you all know the Green Oak, as it was then, is like, a
yeah,
mile and a half down that way." Yeah, we know. So why hasn't everybody gone?
yeah.
And my point is that kind of when we're in clinics, we kind of sometimes fall into this illusion
Mm,
that it's our clinic that's artificially
mhm,
stopping people from drinking. And
mhm,
it comes back to that thing about being in two minds all the time. People have
yeah,
come to us because it isn't working. If it is working,
yeah,
they'd be doing it. I
yes.
mean, and if they struggle with that during an episode of treatment, I think if they're honestly prepared to come back, I mean,
Mhm,
because I mean, that's something I think's interesting is that people outside, even though we
mm,
have a swimming pool, we make treatment kind of, beautiful food, we make it
mhm,
as pleasant as we can, but that emotional journey is kind of one of the hardest things I ever
mm,
did in my life. And I kind of think people sort of don't really recognize how hard it is
yeah,
to kind of realize that things have been going so horribly wrong and then come in and start talking
mhm,
about it. Now, if you add to that somebody,
mhm,
kind of self-harmed or they drank or whatever,
yeah,
why wouldn't you work with that, I suppose,
mhm,
is my
mhm,
thinking. I mean, if they want to kind of stay in the place and carry on drinking, that kind of
mhm,
doesn't make sense. There's
yeah,
cheaper hotels than us.
exactly. Yeah.
So there's that point. But if they've
Mm,
gone out and they've made a mistake, that's surely part, if we
mm,
understand it as a mental illness, that's part of
yes.
the mental illness. We just work with that, I think. I mean,
Yeah, no, absolutely. I understand that. And it's truly about empowering the client,
yeah,
the patient, um, but at the same time creating this trust, therapeutic trust that whatever happens, you are here welcome.
yeah,
This is the safe,
exactly,
so
exactly.
that's your safety net. You can
Yeah.
reach out because what I also often see is like this rehab hoppers. Okay, it
Uh-huh.
didn't work up here. I try here.
Yeah, yeah.
I know you mentioned like with the therapist, so the individual therapist, but then you lose also the history and the
Yeah.
connection.
Yeah.
Mm,
I don't mind that so much
yeah,
because I kind of feel like maybe they are hopping and they are just trying to find the right fit for
what
them.
works for them.
And that's okay with
Mm,
me.
mm,
And we might not be it. I mean, you must have that same thing where kind of like if
mm.
somebody isn't feeling it with us, then hey,
Yeah,
look,
that's fine.
we're gonna
Uh,
we're gonna work with you to help you find, wherever else you want to go.
exactly.
I mean,
Yeah,
and also if you go
yeah,
there and you want to come back, well, that's fine too. I
yes,
mean, it's that whole thing
yes.
about letting people kind of
Mm,
make those choices and
mm,
having the kind of,
mhm,
you know, feel welcome that they can come back
mm,
and that it isn't kind of
yes.
humiliating or anything like that, which it used to be. I mean, that
Mm,
used to be the kind of
mm,
mentality of kind of clinics of
mm.
old.
Addiction is not is part of mental health, and
100%.
you mentioned also your depressive episode
Hmm.
where you had some suicidal
Hmm.
ideation and attempt.
Yeah.
Can you tell me a bit more about this time?
The weird thing with kind of depression and anxiety is how they kind of like, oh, actually, it's true with everything, I suppose. I was going to say, is it different to addiction? But actually, all of mental health problems are weird in the sense that
Mm,
they kind of build up over time. And because they take a long time to kind of build up,
mm,
we don't really notice. So, I mean, I remember with the progression with drugs, for example, kind of like, okay, I'm drinking now, I'm stoning. Um, and then it was all kind of class A, stay away, but
mm,
I'm going to do a bit of coke because it's organic. You don't want to do any synthetic drugs, and heroin the same. It's kind of organic and like
mm,
romantic, and I don't know, you know what I mean? There's all these kind of rationalizations that we use, and it's insidious how kind of slow but kind of
mm,
perpetual that kind of progress is. And it was the same with depression, that it was kind of, I think there were particular triggers, a kind of relationship breakup and stuff like that. But then I also wonder, well, that vulnerability was
mm,
always there, and it kind of built up. And then, I mean, kind of like, I suppose trigger warning. But I mean, I kind of like, I work with people who are kind of
mm,
suicidal, uh, um, and and I think it is important. Like it is. It's not essential, but I think it's helpful sometimes that
mm.
we've had some of these experiences that
Yeah.
we can openly discuss. Kind of being in. I mean, it felt like a fight in my head every day between a
Mm,
part of me that was trying to live and a part of me that wanted to die.
mm,
And so yeah, kind of lots of trigger warnings here, please, guys. I don't want to trigger people, but um and that creates a kind of real feeling of madness, genuine madness. I
mm,
mean, if the brain is trying to end its
mm,
existence, and also it just doesn't really work. I mean, when I got really, really depressed and obviously probably quite mentally unwell, it's
mm,
kind of, it's super frustrating because you can tell I like to think, and
mm,
you know and suddenly to find that thing that I use to exist and to gain enjoyment out of life just doesn't work. I mean,
mm,
was really misfunctioning and was fighting me,
mm.
kind of.
Attacking you, yeah.
Yeah. I mean, that's really weird. And then kind of
Mm,
like led to me, trying to take my life and kind of being hospitalized and kind of
mm,
fighting my way back. And it's kind of, and I just think that's, yeah, I think that those kind of experiences of being quite mad, if we just use
mm,
I mean, whether it was with kind of self-harm, addiction, depression, I mean,
mm,
it's another kind of realm of being, and it's a place that I think it's helpful to kind of have been when I'm kind of working
yes.
with clients, that I kind of, I mean, everything to people outside just seems so kind of
Mm,
so easy and so simple,
mhm,
and yet kind of inside trying to work uh, with that in myself or with other
mhm,
people
mhm.
is phenomenally complex.
It's so difficult for someone who has no experience with it to understand why someone would want to end his own life. What would have helped you in that moment?
I mean, the difficulty again, it probably comes back to a parallel with the addiction, because the weird thing was when I kind of tipped over to
Mm,
deciding I was going to end my life. I mean, it's a stereotype. I mean, and I work in this field, and I kind of know
mm,
that there was a feeling of calm and peace because I'd made that decision.
mhm,
And so actually that kind of, and I made arrangements and so on and so forth. Um, so it was over a little bit of time. And I think that's the difficulty. I think, we really need to be able to kind of help people a
mhm.
lot sooner than that.
Yes.
Kind of like, and it's the same with the addiction piece, kind of, I mean, there's some really great sort of services. I
Mm,
kind of a guy I know down in Dover kind of set up
mhm,
a club called Lads, and it was to try to help men be kind of more open about kind of mental health. And he's a
Mm.
firefighter and also runs a boxing gym. And he got really upset that I hadn't thought of it, but one of the jobs that firefighters have to do is to cut people down after they've hung themselves.
Mhm.
And he kind of was cutting down kids that he'd been kind of seeing in the gym,
Yes.
and it really affected him. And he just thought, I've got to do something about this. So he set up this club, and he just thought, do you know what? Kind of men will come down and they'll kind of do a
Mm.
bit of boxing, and then we'll do like a quasi therapy session.
Mhm.
And I laugh because it's really not like traditional therapy in any way. It was
Certainly.
very blokey, jokey kind of. But you know what? People were coming in who had walked back from the edge of the cliff yesterday,
Mhm.
who were not being picked up by other services.
Mhm.
But they would come down to the gym and they would get into that kind of camaraderie. And not everybody was interested in, like, kind of boxing, or they did some MMA stuff there as well. That
Mhm.
would be great, I think, to help people with depression as it happens. But it was actually just the culture. It was just making a kind of safe place that people could come and talk about
Yes.
that stuff. Really inspiring work. And I think,
Mhm.
being able to kind of, I mean, I think it's always this case, isn't it? It's so difficult because people say, "Oh, kind of just talk," or whatever. And I kind
Mm.
of think, I could talk, but you wouldn't understand.
Yes.
I could talk, but what are you going to do with it when I tell you that, I've got, uh, I don't, again, I've got to be careful not to be too triggering here, but I've got a plan, and this is my plan, and
Mhm.
this is how I know
Mhm.
I'm going to end it,
Mhm.
and that's in my back pocket.
Yeah.
And well,
What do you do?
yeah, what are you going to do with that? And that's the
Mm.
problem with the kind of whole, well, let's just talk about it. And that's why I think kind of having these sorts of kind of self-help
Yes.
facilities, whether it be the fellowships or SMART, or that group for mental health lads or
Mm.
whatever. I think when you can kind of, pros and cons, but when you can get people at least in front of you
Mhm.
who you can say that stuff to, and they're not going to freak out, and they've had a similar experience,
Mhm.
that I think is kind of quite helpful. Risky
Yes.
because you're all potentially
Affecting
walking
each
off the
other.
cliff together, but then that, you could say that was the same risk
Mm.
of AA, and that hasn't ended up being the case, has it? It's kind
Exactly.
of, these self-help groups do help.
Mhm. Mhm. I mean, suicidal rates are increasing all over the world, but particularly in the Western world and among men,
Hmm.
particularly also. Um, so I just think, what is it we can do as a society to support that, to reduce it, talk about it? What can we address here?
I mean, I do think it just keeps coming back to that same piece
Mm.
about um, making the kind of help available, and making and modeling that it's okay. And I
Mhm.
kind of like, we're sort of doing that. I mean, people do very bravely come out and, who are in the public eye and
Mm.
act as great role models, and I really appreciate what they're doing. But I think it needs to be more. I'm more interested in the kind of organic and local stuff. Like,
Mhm.
that's why I mentioned that guy in Dover.
Yeah.
Um, it's having that sort of stuff built into the community, I think,
Mhm.
and it does need to come back to the kind of family level. We
Mhm.
actually need the healing on a family and local level, rather than these kind of big campaigns.
Yes.
I think that's helpful,
So
but I think it's more
educating
helpful.
local families.
Yeah.
You mentioned also AI.
Yes.
AI can certainly provide information
Yeah.
and support for families, but it had also recently a negative effect, which was in the media, that he was helped
Yeah.
using AI.
Yeah. I mean, that's one of its problems is
Mm.
sycophancy, and unfortunately, it kind of
Yep.
sycophantically helps somebody end their life. I mean, there's also kind of like
Mm.
the thing about kind of potentially AI psychosis, which
Mm.
is that when we are interacting with a consciousness, which we almost certainly will be in the very near future, but it's a
Mhm.
kind of, it's an apparent consciousness. I mean,
Mhm.
it's gonna get very messy and very confusing. But
Mhm.
I also think that kind of with every technology, there's a kind of
Mm.
there's a downside. I mean, when we brought cars in, people got knocked down.
Yes.
When and people still get knocked down
Mm.
every day, but we haven't stopped driving.
Yes. Good
And
comparison.
and I think kind of the reason I make that comparison is that also see, which people don't talk about very much, this amazing potential in AI to offer people help.
Mm-hmm.
I mean, I already think, I mean, it's been really annoying because as a
Mm-hmm.
therapist, I've been trying to see how we can, kind of use it and improve it, and kind of you can tell that it's programmed by kind of California tech bros,
Mm-hmm.
because it just comes back with this kind of relentless sort of positivity and
Yeah.
chippy, kind of chivvy kind of remarks. And it's so annoying because actually
Yes.
what you want is a place where you can have a more honest kind of conversation and
Mm-hmm.
explore difficult feelings. And ironically, at the moment, I'm finding Grok, I hate to say it, kind of a better model for that. Um,
Mm-hmm.
because especially in the kind of voice mode, if you try it,
Mm-hmm.
uh, because it's not trying to be as sycophantic. And
Mm-hmm.
it's a bit like, what's real therapy? Is a real therapy somebody kind of chivying you along and just trying to make you
Mm-hmm.
feel better? Or is real therapy exploring the kind of the difficult feelings?
Mm-hmm.
Real therapy is in the difficult feelings.
Yeah.
So that's where kind of Grok leans.
Mm-hmm.
Um, you know,
They
or
will
maybe it's
get
good.
they will get better, certainly
It
day
will
by
always get
day.
better. Yeah.
And I agree with you. At the end, it's a net positive
Yeah.
and good comparison with the cars. Um, tell us a little bit about the work you do at Promise.
Uh-huh. Well, um, so kind of, I mean, Promise has kind of evolved because it was,
Mm,
as I said, started by my parents in '87, and I mean, it was incredibly innovative back then. I mean,
mm,
it had an addiction questionnaire my dad created that tested for 16 different dimensions of compulsive
mm,
addictive behavior. So if you think 1987, like
mm,
acknowledging, kind of eating disorders as part of a kind of compulsive process, and
mm,
relationships and gambling, and, not just kind of alcohol and drugs, that was really pioneering in
mm,
1987. And he also kind of started a kind of research program.
mm,
So this idea that whatever we did should be kind of evidenced and evidence-based. Um, and also he enshrined in that early stage the idea that it was a dual diagnosis, as it was called. They're showing my age now. Dual diagnosis back then. So in other words, it was helping people with other
yeah,
mental health problems, not just addiction.
yes.
And I think the kind of fourth kind of component was his kind of, he was a very creative guy. He was a
Mm-hmm.
musician. He'd been an opera singer as well as a doctor, and like, just, I mean, he's now still composing. He's 87, and he
Mm-hmm.
kind of
Nice.
composes music
Yeah.
every day. He's like, just relentlessly kind of creative guy. And I think he wanted that
Mm-hmm.
quirkiness and creativity to be at the kind of heart of the clinic as well. So,
Mm-hmm.
um, I mean, I've carried on with my wife, and it's still, it's still kind of following those kind of broad
Mm-hmm.
principles. I think some of the things that have changed have been, at one time it was very much an addiction clinic, and I kind of
Mm,
moved probably 2010 to being more a mental health clinic. I mean, we see
yes.
a lot of addiction, but probably half our clients are kind of general mental
Mm,
health. And along with that, I wanted to get away from, I mean, again, when it started, it was literally a kind of what's called a Minnesota model, kind of 12-step kind of clinic.
yes.
And I'm, yeah, huge fan of the 12 steps. I think it's a
Mm,
fantastic program. But I feel that, we shouldn't be kind of saying, if we've genuinely evidence-based and we're
mm,
saying we're offering clients choice, we shouldn't be saying that kind of there's only one treatment. We might say
no.
there's a preferential, there's a better treatment.
Mm,
But if somebody's kind of rubbing up against it for any reason, if they've got a
mm,
preconception or they've had a bad experience, there are other very well evidenced
mm,
treatments, sort of MICBT, there are other organizations like
yeah.
Smart, LifeRing, etc. And if we're talking about kind of first 12-month outcome, the outcomes are the same. I mean, there's a
Mm.
huge kind of religious wars about kind of recovery, aren't there? So I've got to be careful that I don't kind of offend anyone. But my feeling is like, if it's working for you, that's great.
Mm-hmm.
And if it's going to get the same kind of level of abstinence and somebody takes this path, now
Mm-hmm.
you got to look at kind of longer term and stuff like that, and what's going to be easiest and what's going to be most accessible and all that kind of stuff. So there'd be many reasons to kind of probably favor the 12 steps,
Yes.
but it's none of my business to tell somebody
Mm-hmm.
that that's what they must do when I know there are kind of equivalent alternatives. So
Yes.
I
Yes.
kind of moved us away from that, and I moved us away from, we only had people in recovery with their own experience as therapists, which is a pro and a con. I mean, it's great if you can kind of quickly identify with people and reduce the shame and all of that kind of stuff. But the risk is that if the only tool you've got is a hammer, you're going to see every client like a nail.
Yes.
And if all your kind of staff are in recovery, then they work less well with kind of other mental health problems because they just kind of try to reframe it into a kind of 12-step narrative. And I think that's really unhelpful. Now, actually, we do have really sophisticated kind of therapists in recovery who, but it needed actually a change in the team to balance it so that kind of there was a chunk of people who are kind of in recovery, but there are a chunk of people who are, who are not, who are just professionals as therapists and psychologists, etc. And that balance, I think, is really good and is really healthy and changes, and we are 12-step friendly in the sense that, yeah, absolutely, we're going to support a 12-step recovery, but also, oh God, I suppose I have a bit of a problem with kind of clinics just introducing people to the steps and taking people through the steps. I can't see, and I love looking at research. I can't see the research that says that working through the steps increases sobriety. So I'm kind of, I'm struggling with why people are spending all their time on that. Now, I can see masses of research that says that being in meetings, having service, all these things are massively associated with sobriety. But if they're so easier to see and working the steps isn't, that kind of brings up a question for me. And I kind of think, really, if you've got this crucial time and somebody's going to be sober and they're going to be open to therapy, I don't think all that therapy time should be spent working through the 12 steps. I think it should be exploring a panoply of therapies. And there's nothing in the 12 steps that I disagree with. I mean, it says that it's easier to stop, that we need help, that we need to look at kind of a deep exploration into our life, make amends for the things that we've done wrong, and, live a good, orderly life now, in kind of balance. I mean, that's,
Yes.
they're common sense, well, not common sense, but they are, because they're profound and they're important, but they are the same principles that you would find in, I don't know.
Behavioral therapy, psychotherapy.
Exactly.
But
Now,
on an individual level. And that's what people are looking for.
Exactly that.
Because we are much more unique than we think. And if we put therapy just in a box, it wouldn't work for everyone.
No.
So flexibility is needed.
Yeah, and helping people explore open-mindedly. And that includes if somebody's kind of like really rapidly against the 12 steps for some reason. I mean, I'd be interested to explore what that's about, because one of the things that I find funny and enchanting about the 12 steps is its anarchy. There isn't any kind of there isn't any meeting that you can say is definitively 12 step. They are all completely different. And so, if you just get a few people in a room and they can be, as long as they kind of basically follow the core text, it is a meeting. And so, like, there's not much to really rail against. I can rail against lots of people who profess that what they're doing is the 12 steps, who've kind of like underlining every third paragraph of the big book and can repeat it by quote. But then that's like comparison with, religious fundamentalists who can quote every text of the Bible, but don't live like any of the kind of spiritual figures they're supposedly, worshipping. So I kind of think it's the same in kind of AA. And so, I think, or the fellowships in general. And I think, I think it's so available and so easy. If you don't like kind of the meetings that are out there, set one up yourself, because there's a need for it. If you found that people don't, you don't find one you like, then there's probably other people like you.
It also shows that more and more mental health issues coming up, or people with mental health, purely mental health,
Mm,
non-addiction
yeah,
related, um, need help and support. Is this
definitely.
the reason why you are also involved now with Cardinal Clinic?
Yeah, so kind of out of, I suppose, kind of promise, we work up to a kind of like a certain kind of acuity level, kind
Mm-hmm.
of certain severity of problems. So if somebody's, we have 24-hour nursing, we have
Mm,
psychiatrists who kind of visit and so on and so forth. So we're working at quite a high level
mm-hmm.
in the other clinics. But if somebody goes to a point where they need, say, half-hourly obs by the nurses or
Yeah.
something, we're not gonna be able to do that. So we would need to refer them, and we would
Mm.
often refer them to Cardinal.
Okay.
And then, just like bizarrely, we found that it was struggling, and the family was super kind, and they kind
Mm.
of connected with us. And it's the weirdest business deal I've ever done. And actually, the family who did the deal said, well, that's because it's not a business deal, basically. They just kind of came together and made it kind of happen for us, because they know that kind of Johan and I hold,
Mm-hmm.
cherish the values. I mean,
Yes.
the founder was a guy called Dr. Leslie Morrish, and he was kind of one of these kind of
Mm-hmm.
mercurial kind of creative pioneers,
Mm-hmm.
and brought his very much his spirit to the whole place. And we really wanted to kind of honor that, and we would understand, as both,
Mm-hmm.
having families in this field,
Mm-hmm.
we would want to kind of carry on that spirit and that memory, and carry on the kind of good work that he started. So yeah, it came together. But it's interesting moving out of, it kind of starts off where
Mm-hmm.
kind of somewhere like, another clinic kind of
Mm-hmm.
lets go. So, and then we're working up to, we have the capacity to kind of detain someone under the Mental Health Act
Yeah.
if we had to. It's not something that we use. And so I suppose we're going up to that level. Now, I think the
Mm-hmm.
reason we don't use it is that if somebody really needs to be, like, virtually physically restrained, then
Mm-hmm.
there's not really the opportunity to do any kind of therapy, and we're not the right place. So,
Mm-hmm.
there are units that do really good work that
Mm-hmm.
literally just keep somebody
Yeah.
physically kind of safe, and that's all they do,
Mm-hmm.
effectively, and that's all the person's capable of
Mm-hmm.
receiving at that time. So kind of, yeah, so we're now in that kind of higher kind
Mm-hmm.
of bracket of kind of acuity,
Yeah.
which is really tricky. I mean,
Mm-hmm.
not for the obvious reasons of the kind of heightened kind of risk, but it's the kind of dovetailing of fluctuating of kind of therapeutic need. Because,
Mm-hmm.
okay, just because you're kind of right up there at a kind of risk level doesn't mean that you're not able, I mean, at this point,
Mm-hmm.
not able to access therapy and wouldn't benefit from good quality therapy.
Yes.
So kind of trying to weave that into an environment that's set up for kind of high
Mm-hmm.
acuity, and also try to make it still feel as humane and kind of personal. And like, we've got a swimming pool, we've got little kind of, what are they called? They're like little deers, basically. They're Mount Jack, I think they're
Yeah.
called. They're like, so it could be completely surreal. We'd be having a therapy session, and a little kind of baby Bambi goes like bouncing past the window, and
Mm-hmm.
it's like, but it's lovely. And I think
Yes.
that, rather than the kind of boxy kind of clinical
Mm-hmm.
environments that people so often end up kind of having to use,
Yeah.
kind of having that, we've got a piano, and it's like lovely listening to people playing, or in
Mm.
the evening, just kind of, that whole kind of clinic
Beautiful.
vibe, when it's a lovely
Yeah.
vibe. And you couldn't imagine you're actually in a psychiatric hospital kind of
Mm-hmm.
up at that level of acuity. But
Mm-hmm.
I think that's the
Mm-hmm.
beautiful thing to be able to do. And we were kind of frustrated that people would come to our type of service or your type of service, and then kind of,
Mm-hmm.
when they were entering other kind of mental health facilities, there was a mismatch.
Mm.
There was a jarring of the kind of culture and the experience.
Yes.
Um, and so we really wanted to kind of fill that gap and say, actually, no, kind of,
Mm-hmm.
people can come here and kind of still feel that it's that same
Yeah.
principles of treatment.
No, it's highly needed. I
Mm.
truly believe it's highly needed, and we get a lot of inquiries where we cannot take on because of the unstable severity, and they would need another setting. We have been struggling in the past also to find the right ones. Maybe we
We
can do
should
some
talk.
work there.
Yeah, please.
Robin, what do you do in your daily life to stay in balance?
Oh God, yes. I mean, I honestly, I'm not sure that I do, because I still have this kind of drive and this kind of sort of
Yeah,
passion, and so I'm not sure that's great balance. But I definitely married better than my wife did, and I would say
me.
kind of my kind of family are kind of the most grounding thing that I have.
Yes.
And it's a cliche, but it's also true,
Yeah.
and we work together very much.
Mm-hmm.
And she's my wife's from the Ivory Coast, and she's looking to kind of try and bring this treatment
Yeah.
to the Ivory Coast and to other kind of parts of the region. And I think, yeah, I think working together and kind of
Mm-hmm.
living together, and it's been a long time. We've been together kind of 20 years. So, um, but I think I owe that to her, not to me. Like I say, there's only room for one kind of
Mm,
truly mad person in this relationship, and I've taken that slot. So I'd say that that and also
mm,
still being passionate. I always think we're so lucky that we
mm.
work, for people we like, subject we like,
Yeah.
with people
Yeah.
we like.
Yeah. Yeah. No.
And a subject that's still kind of very much evolving. It's
Mm.
exciting. So yeah, that is a massive blessing.
No,
I don't
and I
need to
can
be.
see you are eager to learn, to stay on top of what works, what doesn't work, and still adjust and be flexible
Mm,
in every little detail you do.
mm.
That's what I admire about you a lot.
Oh, thank you. Well, you bring also a very, very calming presence, and it's been lovely to be kind of interviewed by you.
Yeah.
Was very anxious in these situations, but it's really been a pleasure. I've been really glad to
No,
have this
absolutely. I have
experience.
one
Thank you.
last question to you.
Okay.
What, if you could speak to everyone in the world right now, what would you suggest everyone to implement in their life?
It's kind of one large thing, which is this kind of concept of kind of the sort of self-parenting and the
Mm,
kind of self-compassion thing, and
mm,
learning to be able to do that bit. Because if there've been bits missing in our kind of um, the parenting that we were offered when we were kids,
yeah.
I think it's sometimes the most difficult thing to do. But that kind of
Mm,
self-parenting and the nurturing, kind of the whole inner
mm,
child thing, and that
yes.
kind of work, I think, is the greatest.
To dive deeper into that.
Yeah, the kind of
Mm,
self-compassion and kind of self-parenting, because sometimes it's, yeah,
mm,
anyway, I that would probably
mhm.
be the most important thing.
So we'll do another podcast about that topic slowly.
Love to.
Thank you very much for taking the time. I appreciate it a lot, the conversation. I also appreciate a lot the work you do, and with integrity and compassion and a lot of passion also for the industry, that not just you as an organization come forward, but help everyone else, to be innovative and think and improve the service
And
provided.
you too, and
Yeah,
thank you for this amazing forum to be
yeah.
able to discuss these ideas. Thank you.
Welcome. Thank you.
Thank you.